Good morning. My name is Dipak Kalra, the President of the European Institute for Innovation Through Health Data. I'd like to talk to you about health informatics standards, and I'm sorry that I'll be speaking to you virtually, and I'd be much happier if I was with you in person. This lecture is in honour and memory of the late Ragnar Nordberg, and I'd like to tell you about my interactions with him first. I didn't know this until recently, but Ragnar started in atomic physics and worked initially in IBM for many years, where he encountered, interestingly, Bill Gates. We don't know the details of that conversation, but it's interesting to know that he did interact with Bill Gates. Now, in the 1980s, Ragnar did shift to health and initially started in clinical chemistry and then took on a broader health informatics and IT role at the Sahlgrenska Hospital. In parallel to this, he became involved in health informatics standardization, working with the Swedish Institute for Standardization and also at a European level with SEN and then internationally within ISO. He had a special interest in security and privacy standards, and that's where I met him when I was embarking on my standards development career, where he proved to be a great mentor and guide to me personally, for which I'm very grateful. He also founded the Days of Law conference in which we are meeting today and led it until he sadly passed away 18 months ago. I'd like to place my talk on health information standards in the context of health, healthcare and societal needs, because I believe we should look upon health data as a kind of service, a servant almost, to the needs of health and healthcare and our society. When we look at the health systems of today, especially in Europe, but probably globally, they are struggling with budgets, especially after COVID. We have seen a great consumption of public spending, and that is going to leave inevitably less money for further advances in healthcare. And health systems have to look at how they can deliver the best value to their patients with the budgets they have. This is even more challenging than it looks because health demands are going up, we are aging, we are collecting chronic diseases, and therefore our health needs and our health demands are going up. Also, there is a concern, which I think is very right and proper, that everybody should have access to high quality healthcare, which means we have to make sure health systems are more equitable. That means health systems have to transform, and that transformation has got to be evidence-based and therefore inevitably data-driven, and that's where health data is so important. Chronic diseases are one of the biggest challenges for healthcare, health systems, as well as for the population who have to deal with the quality of life burdens that chronic diseases bring. If you take as an example, though, something like cardiovascular diseases, what we have shown is that if you introduce digital innovations such as telemonitoring, you can make a big impact not only on the health system burden, but also make a big difference to patients. If you look at this slide, what you see at the bottom is improved survival rates. In other words, the introduction of a digital tool to support patients managing themselves at home not only eases the cost and effort required by the health systems, it improves patient lives. And that's a critically important thing to remember when we think about digitization of healthcare. It makes a real difference to people. Now, when we look at patients and bring them into the picture, rather than treating them as passive recipients of care, what do they want to do? We risk ignoring the patient as a player in the health data space. So this slide is a busy slide. It's just full of things, but it's just a collection of many ways when we speak to patients, when we look at patient portals, when we look at apps, they do all of these things and they want to do more of these kind of things. So we must remember the patient themselves as actors in the health data space. And in the bottom right, in a red color, you see that patients can be encouraged, and if they are given assurances of privacy and protection and security, to contribute their data for research and allow their clinical data to be used for research. The opportunity for us to learn from data is huge. There are massive volumes of data being collected right across the health and even non-health ecosystem that is relevant to learning about health. We need, however, to pull this data together and make it more amenable to care improvement decision making so that we can transform the lives of our patients. Learning health systems do just that. They study the data on the patients they're treating, look at their care pathways and work out where they could make improvements to those pathways. They implement the change and then they look to see, have we changed the experience of our patients? This slide illustrates one large learning health system that was able to do exactly that and to introduce transformational changes. Look at the percentages of reduction in deaths and complications. That is a breathtaking change in the experience of people, real patients. That's what we must aspire to do right across the health system. In our institute, we believe that a vast range of stakeholders need to work together in order to take us to the next level. We need to collaborate in order to capture and share better quality, more interoperable data, and to use that data in trustworthy ways that society will support so that we can have smarter healthcare and more efficient research. We need, therefore, to bring these stakeholders together to help them to understand each other's perspectives and to work out how they can collaborate with each other to achieve these ambitions. Now, are standards important? The answer is actually yes. All of these different stakeholders want to make better use of data themselves, and they recognize that interoperability standards are critical, because without the ability to connect the dots on data, if we live in a world of data silos that we can't share because either the data are not interoperable or we don't trust each other or the security isn't good enough, we will fail our citizens in society. Patients want to have safe, effective care. Professionals want to be connected with each other. They don't like working in disjointed, fragmented sub-teams. Researchers want to accelerate research, and organizations want to improve the quality and safety of the care they give. This slide has at the top a link, because we felt as an institute it was important that the public should have a better understanding about interoperability and standards. So this is a portal that we've created. It's just at the beginning, or we want to grow it over the coming years, and maybe you will help us with that, to help the public really understand why standards are so important and why interoperability is so important. Patients are an important example of where the lack of standards today gives rise to challenges for them, with duplications of having to report the same information to multiple people, non-joined up care, and also potentially delays in getting to the right diagnosis, maybe even more dangerous issues like being given a treatment that they might be allergic to because the allergy isn't available to the prescribing clinician. So we need patients to understand the importance of interoperability standards and how their adoption could help them to have a better, more efficient and safer healthcare experience. I'm quite keen to bring patients into the standardization landscape to let them become informed champions of standards adoption. And I hope we achieve that through this interoperability portal. I've mentioned standards a few times, but what is a standard? So a standard, usually published as a document, but it can be a technical artifact, aims to bring order to a given context. In the case of health data, it may be relating to how information is represented or communicated or stored or protected. Standards are developed by multi-stakeholder consensus and then endorsed by a recognized body, usually through a formal ballot, which gives it the status then that allows countries and companies to adopt it and thereby to be compatible with each other, bringing that desired order into the system. There are different kinds of standard. The ones with which you may be most familiar are legislative standards that are developed and published by standards bodies such as SIS in Sweden, CEN in Europe, or ISO internationally. These work in the way I just described, a multi-stakeholder consensus-based approach. Usually a network of member bodies offer experts to help develop that standard, and then all of the national bodies vote on it, pass it, and then it becomes endorsed and adopted across those participating countries. Now in Europe we also have European regulations which are developed mostly by the European Commission and passed by the European Parliament. It's then an obligation on European member states to enact that regulation in national law and make it therefore something that can be standardized across Europe, giving everybody confidence that the same regulation is upheld all over Europe. There are also professional standards. For example, a medical professional body may publish a code of conduct or other standards that it requires its members to uphold. And then there are industry standards where a collection of companies may come together and develop a standard that allows them all to cooperate with each other in particular areas, and you will be familiar with things like mobile telephony, where you can roam between countries because of standards that allow your voice to be communicated between the different countries. There are many different kinds of standard, and on this slide I've listed just some of the standards that apply to electronic health records, to patient data. And although there's lots of detail on the right-hand side, please look at the left-hand side and you can see the main categories. And I hope from this you can recognize that there is a need to have different kinds of standard that deal with different aspects where order needs to be brought in to avoid chaos. Things like information models, clinical knowledge representation, message models, and very importantly, of course, privacy and security standards that help ensure trust between the systems that might collaborate in sharing electronic health record data. As an example of the trust situation, when electronic health record information is to be used and relied upon in different places, for example, when data is communicated between hospitals or between a hospital and a GP, the receiving system and the receiving people need to be confident about the information they've brought in. For example, they need to be clear about which patient the data refers, who created the information they've received, when was it created, and things like the units in which measurements were taken, the coding schemes and the language in which text expressions are communicated, which drug coding scheme was used to represent a medicine. Those pieces of information are vital to ensure that the data is understood correctly on receipt and trusted appropriately. Health information is sometimes modified when there is a correction of an error or an update, so people need to know, have I got the latest version? Have I got the most up-to-date list of medicines or allergies? And also, the information has to be protected. Who is allowed to see the information that I've just been sent? Can I share it with anyone, or do I have to treat it with some degree of privacy? Who has seen the information, and is it being backed up appropriately? All of these things enable people to trust electronic health record information when it's moving around between systems, potentially between countries. When it comes to communicating clinical information, electronic health record information, we need the meaning of the data to be understood. This is especially important when we're sharing information between different hospital information systems, GP systems, and other health and care organizational systems that may store the data differently internally. They've got to be able to map the data to the standard so that they can exchange and understand each other's information when it's communicated. An information model provides the basic structural organization that everybody has to map to. And then on top of that, we need clinical models, sometimes known as electronic health record archetypes, that show how the particular clinical findings and features are structured within the model so that people know where, for example, with a prescription, will you find the drug name or the dose or the strength or the route or how many days the patient needs to take the course, so that there is predictability about the shape of the clinical information. And then when it comes to the actual data points, the values inside that structure, people need to know if it's a coded term coming from a terminology system or a database, which one it's come from. For example, if a drug is identified by its identifier within a drug dictionary, people need to know not only the identifier, but which drug dictionary has that identifier come from. Now, the electronic health record communication standard that I had the privilege to lead in ISO and CEN, initially actually some years before, and then the latest version published in 2019, is a method of doing exactly what I've just described. It's a portfolio of 5 standards all bundled into one. So of course the 5 parts have to be mutually compatible, but they represent between them a package of, I guess, really tools that allow people to communicate data reliably between systems. There's a reference model, an archetype specification, that is the clinical models I described, some term lists and things, and an important security standard that I'll mention a bit later. Just to give you a feeling for what an information model looks like, well, it looks like this. The main thing to understand is that an information model is very formal and very strict in defining how the information should be organized. If you could imagine headings and subheadings, and for each one of those there are certain information properties like dates and times that have to be provided so that the overall structure of the electronic health record is always the same, irrespective of which patient it is, irrespective of whether the details being communicated are an operation note or a discharge summary or the examination of a patient or a complicated treatment plan. Always the information has to be structured in the same way. That's what these kind of models do. Complicated to look at, but the most important thing to understand is that they are strict. They impose something that any system can reliably map to and import from. Another standard that is complementary to the one I've just described is known as CONSIS. It is a standard to define how health systems work. How do they organize themselves and deliver care to patients? Who are the different actors in the health ecosystem? How do they collaborate? What are the processes of care they undertake? And what are the kinds of outputs that those processes generate? And how do these result in good quality plans, actions that give rise in the end to good quality patient outcomes? Now, these last two standards actually work together very well, because the electronic record standard is a structural standard that allows patterns to be defined, and CONSIS defines the patterns of care that might need to be documented in an electronic health record system. So what we have done is brought these two standards together to define a library of clinical documentation patterns that are in fact published as one of the parts of the 5-part standard I described earlier. This is an example of where standards teams can work effectively together to make sure that their standards can be used in cooperation with each other, which is extremely helpful to the adopting community, such as companies and healthcare organizations who often need to use multiple standards and want to find that they can use those standards in a complementary, additive way without any complexity. One of the important patterns, if you like, that Europe has really spearheaded is the patient summary. There has been a huge amount of work working closely within multi-professional teams in Europe, but also collaborating globally on what are the main ingredients of a patient summary that would make care safer and more efficient if a patient needs suddenly to have unexpected care when visiting another country, or even in the same country, but somewhere where their normal detailed records are not available. This standard has been implemented in many countries now and is potentially able to give a large number of mobile patients, whether they're business travelers or holiday makers, a safer healthcare experience should they need it. Now, we also look forward to this growing volume of patient summaries as a tool supporting coordination and learning from this vast collection of data to improve quality and safety of care. However, I have to be honest with you that we are still at the beginning of tackling the vast complexity of health information. You can see, building on this slide, the very many areas of clinical data that have to be standardized using clinical model patterns built on top of reference models, connecting with the continuity of care models. We still have a lot of work to do in standards development to formalize all of these. The problem is actually slightly more complicated than this busy slide looks, because different clinical specialties and areas take a slightly different view on the information they most importantly need for each of these yellow boxes. So whether it's cardiovascular medicine or mental health, hospitals or general practice, you can imagine that what they need, what they collect and what they want to receive is slightly different. It's different flavors of the same broad information. So our work to build up these patterns is going to be time consuming and complicated. We therefore have to take a view on what are the greatest priorities. Where could we formalize clinical documentation to make the most difference to patients and to leverage what computers have to offer, keeping us safe, helping us to be efficient, helping us to be most effective, helping us to collaborate. So that's where the effort now needs to be placed. We have quite a good body of standards representing the right-hand side of this slide, but where we need a lot more effort is the left. And now we need to be enlarging the pool of people we bring in to help us to create the clinical specifications I've spoken about. Yes, we still need the clinical community, but we must involve patients. I told you previously how patients are keen to be much more involved as data users as well as data creators. And the importance of research, the importance of public health. These stakeholders need to come together to work out what are the priorities, what is the shape of the data that would make the most difference, bring the best value to society, and can we formalize that as clinical documentation patterns and get everybody collecting and sharing data in consistent ways and delivering those benefits. I've spoken a lot about trusting the data, and of course interoperability is one of the ways of having trustworthy information exchange because the information is communicated in a standardized way. But another area of trust is trusting the quality of the data. And a lot of work has been done in recent years to formalize what are the different data quality properties that can be assessed and can be examined using formal tools, statistical methods, so that you can quantify data quality. I believe that this is an area that is mature enough now that it's time we started making data quality standards. So it may be interesting for you to know the standards landscape is far from complete. As areas of informatics mature, they become suitable for standardization, and then we need to hand them into the standards landscape. For example, to CEN or to ISO to say, can you now pick this up and help us to create some data quality standards that can formalize and make harmonized the way we assess data quality across different communities and different systems. I'd like to turn now to another kind of standard I've mentioned previously, European regulations. The European Commission is currently drafting an AI regulation, artificial intelligence. It wants to protect citizens from being exposed to artificial intelligence that's been poorly developed, not robustly tested, maybe not suitable for that particular aspect of the population or a particular decision, and also to make sure that AI is not used for unacceptable things such as social scoring. So the new regulation will specify rules for each of the colours on this triangle and help to ensure that all member states pass legislation to ensure that AI is developed in trustworthy ways and used in ways that are societally acceptable. A different kind of standard, a legislative standard, but really important and complementary to the other standards I've described. I've emphasized societal trust a number of times. This study is a little old, but I think it's still completely valid. When you ask European citizens about what they are concerned about when it comes to the digitization of health and care, their concerns very much highlight anxieties about privacy breaches and cybersecurity. So we have to take data protection and information security seriously if we are to succeed in scaling up the collection and good use of electronic health records and health data generally, and to keep societal trust. Another important European regulation that enforces data protection practices is the General Data Protection Regulation, the GDPR. This places an obligation on any organization that collects and processes or shares personal data, such as health data. For example, it makes very clear that the individuals whose data are being collected and used must be informed about why, how, and for how long their data will be held. The data that the controller holds must only be collected and used for the purposes that have been agreed. In other words, if you ask a patient for consent to use data for a certain purpose, you can then only use the data for that purpose and for nothing else. You should make sure that the data that you collect is only the data that is needed for the purposes you've agreed. You don't collect extra data. You only hold it, especially in an identifiable form, for as long as you need to fulfill the purpose that you've agreed. You should make sure that the data you are holding is up to date, and you should have a method for making sure it remains up to date. For example, if you have an allergy list or a medication list, you should have a method of making sure that you are always working with the most up-to-date medication and allergy list. Once you no longer need to identify the person whose data you're holding, you should de-identify it. For example, if you have permission to hold on to data in the longer term for research purposes, but you no longer need to know who each individual is, then delete those properties so that the data becomes anonymous. That is what this regulation asks all data controllers to do. And then, of course, quite rightly, each data controller is obliged to adopt information security measures that safeguard the data and make sure that nothing inappropriate occurs when they're in possession of that data. As you can imagine, there are therefore many different information security standards published by bodies like ISO. Many of these are areas of work in which Ragnar was involved, driving the standardization work or providing his expertise as one of the experts in a team, and in some of those, providing that expertise and guidance to me personally. The principles and the requirements for the consent that you capture in order to collect, use or disclose personal health information, a classification for the different purposes for which somebody might need to process personal information, a rather complicated but very important standard around privilege management. Who is allowed to do what? How do you formalize that so it can be understood and shared between systems? And that means also, how do you classify people into functions and organizational groups? Because it's not meaningful to manage access controls at a personal level. You need to specify it at a group level, at a team level. So how do you define groups and teams so that you can define their access controls? How do you communicate, when you communicate clinical data, also the rules about who's allowed to see it? More complicated technical standards around digital signatures. How do you capture and represent and communicate that you have authenticated somebody, and therefore another system should trust that the person you are telling them about has already been trusted by you, and that the other system can therefore trust the individual as well. Audit trails, I've mentioned it before, but there have to be standards so that audit trails are consistently created and they can be examined in consistent ways. Archiving is something that Ragnar was very passionate about, making sure that when you take data offline because a patient is no longer one of your active patients, do you do so in a way that safeguards that data and makes sure if you ever need to look at it again, it's still in a good shape and can be trusted and used reliably. And then when we move data between countries, can we be sure that data protection rules in one country can be communicated appropriately to the receiving country? These are all examples of security standards, but there are in fact many more. Now, I had, as I mentioned, the personal guidance of Ragnar when I was developing the security component of the electronic health record standard. And here I arrived in this standards landscape with a clinical background, a fairly good knowledge of clinical meaning, but a very limited knowledge of the information security standards landscape. And he, with colleagues, helped me to understand which are the information flows between EHRs that need to be protected and how should they be protected. Some quite complicated models about access policies. How do you explain in a computable way to a receiving system what are the permissions about the data you're giving them so that they can copy those permissions and follow the same ones. And then audit trails, which I've mentioned before. What is the information needed to help a person, whether it's a patient or an investigator, to say who's looked at my record? These are areas of significant complexity that I would have absolutely struggled with, or perhaps even found impossible to do, without the help of wise, kindly security mentors like Ragnar. I am very grateful for the guidance and kindliness that Ragnar showed me when I was learning the ropes on information security and standardization, and I'm sure many of you in the room have very fond memories of him and his wisdom and his guidance. Thank you all for listening.